So when the immune system is overactive, that's what autoimmune is considered inside of our own body. We don't really know why our immune system turns on us. Our immune system is designed to fight off infection, but there are times where we get signals within our body to tell our immune system to fight against ourselves, like our skin or our joints.
Hi, skin friend. I am so glad you tuned into this week's episode of The Skin Reel. This week, I am talking with board-certified internal medicine as well as a rheumatologist, Dr. Brittany Panico. She is going to be talking to us about what rheumatology is. Now, I know rheumatology, it's a tough word to spell. You may have heard it, but you may not really know what is rheumatology, what are rheumatologists, and what the heck do they treat? Well, there is a lot of overlap between rheumatology and dermatology, and rheumatologists in general treat autoimmune conditions. Not every single one, but a lot of them. And a lot of autoimmune conditions are also present in the skin, and there's considerable overlap between the two. And so making sure you have an amazing rheumatologist on your side as a dermatologist is super, super helpful. Dr. Panico is board certified in internal medicine as well as rheumatology. She treats adult patients in her practice in Arizona as well as Oklahoma City. And she provides a lot of telemedicine visits, which is really cool if you're in those states, because a lot of times you are seeing your rheumatologist on a fairly regular basis. So having telemedicine visits is super important. I am so glad she's joining us today to really shed some light on autoimmune conditions, especially the ones that have overlap with dermatology or skin manifestations, because there is a lot. Things like psoriatic arthritis and psoriasis, things like lupus and skin rashes of lupus. We're going to be delving into all of these, plus some of the less common autoimmune conditions that she sees and treats in this week's episode. So if you have an autoimmune condition or you know someone who does, or you're just curious about what autoimmune conditions are, then you are definitely going to want to check out this episode. Dr. Panico, thank you so much for being here. I'm really excited. Rheumatology, it's such an important field, and sometimes I feel like it's really overwhelming. I feel like that was the hardest rotation I did was rheumatology and training, but it's so important. So I'm so glad you're here to help shed some light on rheumatology and some of these autoimmune conditions that are really more prevalent than we think.
Yes, thank you for having me. I'm excited to chat about the crossover. Our specialties overlap much more than I think we admit and talk to patients about. So I think this is going to be good information.
For me as a derm, having a rheumatologist I can call with questions is so important, and probably the same for you too. Yeah, there's so much overlap. Well, I would just love for you to share in your own words a little bit about yourself, who you are, what you do, who you treat and take care of.
So I am Brittany Panico. I'm a board certified rheumatologist. My home base is in Arizona. I practice in Gilbert, Arizona. Then I have a clinic in Oklahoma City or Edmond, Oklahoma as well. So that's been fun, having multiple office locations and being able to treat patients on a broad spectrum. I do a lot of telemedicine, so that is helpful. I do all general rheumatology. So I have a primary focus on gout, psoriatic arthritis, which overlaps a lot with dermatology with psoriasis, rheumatoid arthritis, and then cover all the other rheumatologic things like osteoporosis and ankylosing spondylitis and things that may not necessarily be as crossover heavy with dermatology. Lupus is in there, myositis. So we'll talk about all those different kind of rashes, I'm sure. But yeah, all general rheumatology, adults only. So that's basically the gist of my practice. Summit Rheumatology is where I practice.
I'm just curious, do you go back and forth a good bit, or most of your telemedicine visits?
I do. I travel back and forth. It's mostly laboratory testing that we do. We don't do as many procedures, but there's definitely a need for more rheumatologists out there.
What is rheumatology, right? I think people have maybe heard that word, but they're like, I'm not 100% sure. What does that mean?
So rheumatology is the diagnosis and treatment or identification and treatment of what we consider autoimmune conditions. There's some autoimmune things that rheumatologists do not focus on, like thyroid disease and MS are still autoimmune. But most of what we see are conditions where the immune system starts causing overactivity in the body and particularly affecting the joints and possibly the organs. So lupus, for example, can cause wide systemic symptoms, but then have a rash associated or a couple different variations of rashes. Psoriatic arthritis patients may or may not have visible psoriasis. And so they can also develop joint pain and inflammation. And then rheumatoid arthritis is primarily a joint condition affecting like the hands, the small joints in the hands. And then there's other autoimmune things that we treat like muscle inflammation syndromes and other kind of lesser known syndromes that affect the joints and body. But for the most part, we treat with medication that calm the immune system down. So when your immune system is overactive and causing trouble inside of your body, we aim to calm that down so that the symptoms get better, your pain and swelling and inflammation improve, and you can do, the things that you want to do.
That's a great synopsis and recap. And mostly my practice today is procedural dermatology. So I'm not seeing a lot of this personally in my practice today, but I still get asked questions or patients want to talk to me about their psoriasis or other things going on. Sometimes they think their immune system is actually suppressed. And I have to tell them, like, actually, your immune system is overreacting or fighting yourself. And so that's why you're getting this rash. It's not that you're actually immunosuppressed. So that's an important distinction. And do we know why? Why do our bodies attack ourselves? Like, what causes that?
So you're absolutely right. So when the immune system is overactive, that's what autoimmune is considered inside of our own body. We don't really know why our immune system turns on us. Our immune system is designed to fight off infection, but there are times where we get signals within our body to tell our immune system to fight against ourselves, like our skin or our joints or our muscles and things like that. And some people can identify that it may happen after an infection. So sometimes it happens, after you have a severe viral infection or a really significant bacterial infection. Sometimes it's hereditary. We don't really know why it happens during the phase that it happens, but autoimmune things tend to cluster, especially psoriasis and psoriatic arthritis tend to kind of cluster in families. And so we, identify that's what's happening, but we don't specifically know why it's happening.
I wish we did, right? That would be really helpful. So, and that it's such a broad term too, right? To say autoimmune, right? Your body might have an antibody that's fighting, for skin stuff, we'll have, vitiligo, where it's attacking the melanocytes, so you lose pigment, or alopecia areata, where it's attacking the hair follicles and you lose hair. So it's really just a broad term where your body is fighting against itself and your immune system is either overreactive or acting inappropriately. But well, let's start off with psoriasis, and you see psoriatic arthritis. Those two, do they always go together? How often do they typically go together? If you have psoriasis, does that mean you're going to get joint pain and arthritis?
So that's a great question, and something that we don't have a specific percentage to say, yes, this type of person is going to have both the skin and the joints involved. But we do know that patients with scalp psoriasis, particularly like those thick plaques, even thin scaly plaques on the scalp or inside the ears, or facial psoriasis, right, where they get it kind of on their eyebrows or eyelids. And then patients with nail psoriasis or nail pitting on their fingernails or toenails are more likely, about 3 to 4 times more likely to develop the arthritis component as well. But that's just an estimate. We don't have a specific number to say, yes, you are going to develop, but they're at higher risk if you're somebody with scalp psoriasis or nail psoriasis. There are plenty of patients who develop the arthritis component before we recognize that they even have psoriasis. Some people don't even know. They may just sort of like scratch at their scalp or have a rash that they kind of put on, hydrocortisone on at home and not really notice that it's even bothersome. And that can then be the clue that unites their joint inflammation to the skin. Some people have there's different forms of psoriasis, right? So you can have that palmar psoriasis where you're really just flaky on your palms and soles. Some people have very thick, scaly plaques, over a large body surface area. One of the things that as a rheumatologist, I try to have patients understand is if you have psoriasis, and it's manageable even with topical treatment, right? It's very small and you're not requiring a whole lot of medical management. If you're somebody who has neck or back pain or stiffness, that's something to then at least have a discussion with your doctor or see a rheumatologist about, because psoriatic arthritis, when we think about arthritis, we think about having joint pain, like in our fingers, our wrists, our ankles. But psoriatic arthritis can hide as inflammation in the spine, in the neck, and in the lower back. So people may not even realize that that's a type of arthritis. They may just feel that they have joint stiffness in their back or struggle to get going in the morning and go on with their day without stretching or exercising. So that's a connection that I think a lot of us tend to overlook, because as we start to age, especially, right, we start to think, well, I'm just kind of, I'm stiff and I just have to exercise in the morning.
It's just the way it's going to be.
Exactly. So that might be a clue that something is actually going on. And then also, again, talking about family members, if you have a family member who has psoriasis and you start to develop joint symptoms or you start to develop that skin rash, it could be connected. Sometimes, as a dermatologist, when we think about what psoriasis looks like and what eczema look like, sometimes they're very similar and hard to distinguish. So there's a lot of patients out there who think they just have eczema, who end up coming in for joint pain and swelling, and that rash is most likely psoriasis. It can almost confuse us in a way until we start treatment and then realize, oh yeah, this is getting better because it's psoriatic arthritis.
I'm so glad you brought up that last point, because I don't know how many times I would hear this, or someone would tell me, oh, that's just my eczema. I just have eczema. I'm like, no, it's not eczema. It's psoriasis. Right. Like, I don't expect public to be able to discern between psoriasis and eczema, right? But you're so right on with that point that especially just a small amount of skin, they may just think, oh, that's just always my eczema. I have real dry skin there, and not even really realize it. And then that's a great point about putting it together with joint pain in your spine. I think most people totally think of joint pain just in their fingers or toes, but actually that neck pain and that little dry patchy area that you just think is eczema, they could be linked together and could be psoriasis and psoriatic arthritis. And actually my mom was diagnosed with psoriatic arthritis later in life, and her only skin manifestations were very thick skin on the heels, and she would get pedicures and try to get it like filed down, which is actually the wrong thing to do with psoriasis, because you could get something called Kebnerization. So, she didn't have those classic orangey plaques on the skin or in the scalp to discern whether it was psoriasis or not. And so she went undiagnosed for a really, really long time before people finally put it together that it was psoriatic arthritis. So yeah, it can be tricky. And again, that's where like your dermatologist and your rheumatologist need to kind of put their heads together frequently, because there is a good bit of overlap. And I love it when the skin gives kind of clues to what's going on. So if I can help, if someone is talking about joint pain and I happen to look at their nails, even though that's not something I treat myself now, I'll be sure to tell them, hey, you need to go see a general dermatologist about this or see a rheumatologist.
Yeah. And I think too, there's a broader initiative, to recognize the different types of psoriasis and different skin tones. So primarily we're kind of taught, in medical school and training what psoriasis looks like on lighter skin individuals, right? That reddish hue, you kind of mentioned like orangish plaque. And in people of different skin tones, it can look different. It can happen around areas of scarring. It can happen, very subtly or really intense hyperpigmentation. And so again, thinking about like eczema and not just brushing off, oh, that's my eczema, like you said, because psoriasis comes in so many different forms and looks different in different types of skin tones.
Great point there as well, that it's not always the classic textbook picture for sure. Let's also talk about lupus, because I feel like this gives people a lot of confusion, even in the medical community, right? Because when people hear lupus, they think of a very serious systemic condition, right? Like something that you probably see and treat and manage, right? But there are also other forms of lupus, and there's some that are just in the skin. So can you just share with us a little bit about lupus?
Sure. So systemic lupus is that whole body lupus. So that autoimmune condition where antibodies actually start targeting your body and your organs. So it primarily can affect the kidneys, the liver, potentially the lungs, the heart. It really goes for your organs. The skin can be involved as well, involving that classic kind of butterfly rash that a lot of us talk about. Sometimes you can have lupus rashes on other areas of the face or behind the ears on the scalp. And it typically is kind of angryish looking rash that can lead to scarring and significant thinning of the skin. That can coexist with systemic lupus. And then there's discoid lupus or cutaneous lupus that may not be connected to the overall body autoimmune condition, but primarily just a rash that involves the skin where, maybe a dermatologist would see that patient first. And that sometimes actually looks a little bit like psoriasis. Sometimes it can flake and sort of peel. And so really as a rheumatologist, I rely much more on a biopsy. So if a patient has concern, I don't know what this rash is, our best tool is to look at a sample of what that skin is, what's actually happening, what kind of cells are changing in that area, and if there's immune deposition or immune complex changes that can identify what it is. So we often, send a patient for a biopsy to confirm what that kind of rash is. And then along with blood work, we can identify, is it systemic lupus or is it primarily skin lupus?
We don't always in dermatology do biopsies of rashes. In fact, a lot of times we don't, but if there is any confusion or just to make sure we get that pathologic confirmation that this is lupus, then certainly we send that off. And yeah, I always found it interesting in residency learning that discoid lupus really is not linked with systemic lupus as much as I thought it was. And that's usually when we get these pretty telltale skin characteristics in especially the inner part of the ear, what we call the concho bowl. And you can get some white spots and some dark spots, things like that. It's pretty pathognomonic or highly specific for discoid lupus. But I always found that interesting that it usually wasn't linked to systemic in that case. But yeah, some of the other types of lupus that we see on the skin, like subacute cutaneous lupus, that can be.
Yeah, and oftentimes we'll treat it the same depending on how widespread the rash is or how much scarring is involved. So a lot of our medications and treatment actually overlap and work well for both conditions. But when we think about what primarily affected, it does help to separate, is it just the skin or is it the skin and the body too?
Yeah, because if it's really localized to the skin, we might just use topical steroids or topical treatments. But if it's internal, it can be affecting your kidneys, things like that. We're going to want to use something systemic. So can you talk a little bit about some of the drugs that we use for these conditions?
So for lupus, primarily the foundation that we use is hydroxychloroquine, or its other name is Plaquenil. And that kind of got a rise in popularity during the COVID pandemic. It was being used as a form of treatment for COVID, which as a rheumatologist made us so nervous because our lupus patients really rely on it. And so it was actually in shortage during the pandemic for our patients who need it. And so that's our foundation medication that we use. That's a pill, and it's very easy to take, and you can be on it for long periods of time. And that really just helps decrease the rambunctiousness of the immune system. It's not an immunosuppressant, but it just helps control how irritating your immune system is to the rest of the body, more or less. And so that medication is, again, the foundation of what we build everything else on for lupus patients specifically. And then we have medications that help, again, kind of control the skin rash a little bit. One of the common ones that we use is either azathioprine or mycophenolate. Those are two of the more popular ones that as a rheumatologist will often use that are systemic. So they actually help with other types of things as well. So if you have actual systemic lupus and you have joint pain or you have kidney disease, they can help with that. And then our biologics that are gaining in momentum in the lupus world are Benlysta, which is a subcutaneous injection or an IV, and then Safanello is an IV treatment. And those both work really, really well for the skin. So they've gained a lot of popularity among our patients who have widespread skin involvement. And so those work very well.
Are there any side effects to those? Because I know people worry about, am I going to be immunosuppressed and things like that? What are some of the main side effects with that?
So as we kind of advance with our treatment, some of the side effects kind of change. So typically we monitor your blood work every 3 months or so, just making sure that the medication isn't irritating your liver, kidneys potentially. And then we also monitor your blood counts just to make sure, again, if we are giving you an immunosuppression, we don't want to decrease your blood counts too much. And that's really relative to the dose of the medication that we use. So in rheumatology, we tend to use things at much lower doses. So the immunosuppressive effect isn't as robust as, say, something like chemotherapy. We're not out to knock out your immune system entirely. So we watch your blood work really closely, to monitor for potential side effects. And then with the IV medication, those are immunosuppressive in a different way. So those aren't recommended to take if you're actively on antibiotics or if you're sick. We want to let your immune system kind of recover and heal. And so we'll tend to pause those medications if you have, an acute illness that you're being treated for, or something like a wound. They can impact wound healing. So we try not to use them, if you're undergoing surgery or big procedures that involve, a lot of suturing and stitches. Other than that, these medications are a lot safer than I think, again, the public kind of has an opinion about. And part of the reason that they're as safe as they are is because we use them all the time in rheumatology. They've been on the market for a long time. We have a lot of experience using these medications. And so we know what kind of things to look out for. So if people are running into trouble, then we pause or stop the medication if they're causing side effects. I think the biggest thing in rheumatology that a lot of patients don't necessarily understand until they see a rheumatologist, we see you really every 3 months on average. Depending on if you're a stable patient only on very minimal medication, we may see you every 6 months. But you'll see your rheumatologist a lot more frequently than most other types of doctors that you see and specialists. And so we have a very, tight grip on how much medication you're given at each appointment, the type of dose that you're taking, and keep a really close eye on potential for side effects. So when patients are really nervous about, something causing a side effect or something being severely immunosuppressive, I tell my patients, every 3 months we're checking in. So if there are big life changes that happen, we're likely to capture you within that period of time. So they're not as scary as I think, when you go out and look online and Google these things, all the warnings that pop up. Yes, we do have to make sure that we don't, use these medications while you have an infection, especially TB is something that we watch out for, but we screen for that. We're constantly checking your blood work and checking in with our patients. And so they're really not as intimidating as they may seem.
I think sometimes people think drugs like these antibiotics that we use a lot, they are more familiar with those, so they think those are safer, but really they're probably more harmful than people realize. And then some of these other drugs we've had for ages and ages and ages and we monitor versus some of the side effects with these common drugs, even Tylenol, right, can have some serious side effects and it's over the counter. So everything's got risk. And that's a great point you made about that. You're being followed closely. And when you have these rheumatologic conditions, this isn't something that's cured, right? Like this is something you have for life. And so it's important to have that strong relationship with your rheumatologist because you're going to be seeing them a lot and they're going to be monitoring you closely.
Absolutely. Yes.
What about a dermatomyositis? That's something I saw a good bit of in my training. And I always thought, this is why I love dermatology. I love to be able to look at something and have clues to what's going on internally. And so I always just thought that was so cool. You could look at someone's fingers, their cuticles, these little bumps over the knuckles, and be suspicious that that person may have an internal malignancy that if they hadn't seen their dermatologist may have gone on for months and months before being identified. So do you see much dermatomyositis?
So it's not super common. It's more on the rare side of things that we see. But yes, it's definitely out there. And like you mentioned, when we see a patient with a rash, particularly, more purplish, reddish over the knuckles and changes within their cuticles, like thickening or redness of the cuticles, and then you may have a rash over your chest or your back or even around your eyes. Those things are usually associated with muscle weakness. So patients are very fatigued, maybe losing weight, appear pretty ill. They can be, very sick. And a lot of times, too, we screen for malignancy. So again, thinking about the constellation of symptoms that goes along with that, if somebody's experiencing weight loss, night sweats, dramatic changes in their strength, then we think about, screening for malignancy.
I remember even seeing a patient who didn't even have the myositis part yet. So that's always stuck with me and on my radar. But what are some other autoimmune conditions that you want to share with the audience that people may not be aware of, but are more prevalent than we think?
So one of the interesting things, thinking about dermatology is gout can actually manifest as a skin rash. I've seen that happen where a patient came in with like a bullous kind of like blistering rash, and that ended up being actually uric acid deposition. Where patients can have tophi, where there are these nodules that kind of develop from uric acid deposition. So they may go into a dermatologist for a biopsy of the skin bump, right? And that can end up being uric acid collecting under there. So I think gout is one of the most common types of inflammatory arthritis, but the least understood and least diagnosed. And so really getting the word out there about how gout can look, how gout can present is important, because a lot of us are seeing these patients and not specifically realizing what's happening. And that's a very systemic inflammatory disease as well that can affect things like blood pressure, diabetes, your kidney function, skin, right? If you have one of those nodules or several of them. I have patients with wounds that are, again, from those tophi, those uric acid deposits opening up and causing wounds. So some patients need wound care for that.
And I can imagine on a lower limb, that's hard to heal.
Right, exactly. And painful. They can be very painful. Vasculitis is another thing that as rheumatologists and dermatologists, we both see together. And that is very urgent to address and treat, because that tends to really spread and involve the lungs and the kidneys very quickly. A lot of times we'll see it in younger patients, but it's more common in older populations. So, somebody may just kind of think, oh, I'm just bruising, or I have these sort of reddish, things on my skin that just my skin's getting more fragile. And that ends up actually being a very intense inflammation process that involves the small blood vessels. So we call that vasculitis.
Yeah. And usually like a tip off for like derm people is that when it's non-blanching, which means like if you push your finger on it, it doesn't disappear. It will stay that red color, typically like a deeper color, but it won't disappear, versus if you have like a hive kind of lesion or some other rash, when you push on it, it will blanch or kind of lighten up.
Yeah, exactly. And then there's overlap syndromes. You mentioned hives. Thyroid disease can also involve like urticarial kind of hivish like rash. And so a lot of patients come to us in rheumatology for a positive ANA blood test. And they may have, one of these like urticarial or hive-like syndromes that sometimes are linked to thyroid disease as well. So a lot of times when we think about who's managing that, right? Is it allergy? Is it dermatology? There's a lot of crossover with these conditions about where it's coming from within the body and what it's creating on the outside that we can see.
Well, speaking of ANAs, can you just talk a little bit about that? Because I feel like people have probably heard this. They might even had it drawn and say, well, I've got a positive ANA. Like, can you just talk to us about what that is? And if you do have a positive value, what that means?
So the anti-nuclear antibody, or ANA, is just a blood test that essentially tells us that your immune system is activated. It doesn't really tell us what it's activated to or what's happening. It just gives us a clue that your immune system is doing something. And so it can be positive right after an infection. It can be positive if your immune system is reacting to a certain drug or medication that you're taking. It can be positive for all sorts of different things. And on the result, the test result, part of the reason that everybody gets so excited about it is because it says this test is a screening tool for lupus. So if somebody gets that blood test drawn and it comes back positive, the first thing they see is this may mean that you have lupus. And yes, it could be related to having lupus, but it does not mean that you have lupus. It is not the diagnostic tool that we use to define lupus. And so it just is a gateway. It's something that I tell patients, it opens the door for a conversation for us to have to identify what is causing your symptoms. And most of the time we try to think about that test being drawn if you have complaints about something, rather than just having it be a part of your, yearly checkup. It's really not indicated if you don't have symptoms. And so that's where a lot of times we get into this sort of, we don't really know what it means if it comes back positive and you feel fine or you don't have any symptoms specifically linked to that. And so then we just watch and wait. We watch and see, is it something that's evolving over time, or is it something that you may just have a positive test and it doesn't mean anything? About a third of the population walking around with no clear identifiable symptoms has a positive ANA test. And so it doesn't guarantee a diagnosis of something autoimmune, but it opens the door to more conversation. And I think another helpful tool is really discussing what your symptoms are in a meaningful way, rather than just asking for the blood test or asking for, labs to be checked. Because if you don't have specific symptoms that link to other antibodies or that link to a diagnosis, when you go to visit with that specialist, they're not likely to give you a diagnosis, because we don't diagnose diseases based on a blood test only. We diagnose them based on a combination of your symptoms, your labs, and the way things look. And so it's really helpful for patients, I think, to understand that that test by itself does not specifically mean that you will have an autoimmune diagnosis.
I'm so glad you helped clarify that, because I do see that a lot. Or people say, yeah, but my ANA is positive. And I say, okay, it's a sensitive test. It's not specific to anything exactly. And yeah, just it doesn't need to be a part of your routine baseline screening. Only if your doctor, your rheumatologist, your dermatologist, someone is concerned that you may have an autoimmune condition, would you want to get that checked? So yeah, thank you for helping clarify that, because I know it can give people a lot of anxiety too when they see it come back positive and they think, oh my gosh, does this mean I have lupus? So great point with that. Can you just share with us what are like your top 3 pearls or things you wish the listeners would understand about autoimmune rheumatologic conditions?
So I think the biggest thing for me is really being an advocate for yourself. If something doesn't feel right in your body, meaning you have joint pain that impacts your normal activities like twisting tops or twisting door handles or faucets or things where you have to modify your daily routine, then that means something isn't right. So if you're somebody who is very active and gradually over time you have to modify your activity because of the way your joints or your body feels, that warrants an evaluation and to ask questions about, a potential rheumatologic condition. If you have, a rash or a symptom that isn't getting better with treatment, so you're going to see somebody and they're providing you a treatment option and things are not getting better, my best advice is don't just disappear. Don't say, oh, well, they didn't say I should come back. They didn't set up a follow-up for me. I'm just not going to address it, because that means that the treatment isn't working, and the opportunity to go back and rediscuss what your other options are is so important. So when we have things that aren't getting better with the treatment options that were prescribed, that means then set up another visit and talk about, I tried the things you suggested and that didn't get better. What else are my other options? It really breaks my heart when I have patients come in, years after something started and they say, well, I just didn't know what to do. I didn't go back to the person who tried to treat me. And we don't know if something isn't working if you don't come back to see us. So it's one of those things where, we as patients have to really advocate for our own selves in that way. And then I think the third thing is, help us include members of your healthcare team. So a lot of us in private practice, meaning that we're not part of a big medical system, we don't automatically get your medical records and we don't automatically know what story you've already told to your other healthcare team members. And so it's really important if you have other specialists or you have a doctor that we need to coordinate care with, that you tell us who those people are, right? We want to work together as a team. We want to do this collaboratively. And we don't necessarily know who is on your team unless that information is provided. And to really keep track of your records and keep track of the things that have already been tested for and the results, right? If you have a biopsy done of something, keeping record of that, because a lot of places, people change practices over time. A lot of people move states, and those records can be really hard to track down and get after the fact. And so I think to round out that third one is let us be included in your healthcare team and keep track of as much of your personal medical record information as possible.
So many great pearls and all of those, especially those last two. Gosh, yeah, I'm totally with you where people, they say, oh, it didn't work. It must not work. I'm not going to go back. They don't realize well, that was just plan A. There's plan B and C, and we'll keep working with you until we get it right. Or find someone who can, right? Send you to someone who can. So yeah. And I just think nowadays, right, patients have to really advocate for themselves. And today I was just on the phone with two different doctors because I insisted that I get the name because I really needed to communicate with them something. And I just feel like I didn't know if a fax was going to make it to them or not. But if you give us the name of someone, I will hop on the phone and call them. And I know you will as well. And especially with these autoimmune conditions, right? It's not just one organ. And that's all, you may want to talk with someone's nephrologist, their kidney doctor, their heart doctor, their dermatologist, right? And so making sure that we have that information, that you have that information is really helpful just in giving you the best care possible. Because these conditions, they're not just an isolated one organ system and that's it. It's really multi-system and we got to treat the whole person. So I love those points that you gave. Really, really helpful. This has been awesome, Dr. Panico. Where can people follow you, find you if they want to be a patient of yours? What's the best way for them to get a hold of you?
Absolutely. So I am seeing new patients at both my Arizona and Oklahoma locations. So I'm at Summit Rheumatology in Arizona and Oklahoma. And my website is summitrheumatology.com. And I'm also on Facebook and Instagram and YouTube as Dr. Brittany Panico.
Wonderful. We will include all of that in the show notes so people can just easily click on it and find you. This has been great. It's been a great refresher for me since it's been a minute since I've done derm and rheumatology, or rheum derm, I should say. So learned a lot. And I know this has been really helpful for everyone listening. So thank you so much. And we'll see everyone next week.